begin with the first paper comparing accuracy of toric IOL power calculation as with stress source OCT and standard devices. Chief and the presenting author is Dr. Sanket Bhatnagar. Is not available? Should we move to the next? Okay. Fourth. Okay. So wavefront aberrometer and slit lamp method for evaluating toric IOL position in realignment surgery by Dr. Senthil Prasad. I think you are maintaining with the timings. 6 minutes is the time allotted. Yeah. With me is Dr. Sandeep and Dr. Soni George. They'll be again judging you all. So I think Dr. Senthil is ready for the presentation.
Yeah.
Thank you.
Good morning all. So I'll be presenting on wavefront aberrometer and slit lamp method for evaluating toric IOL position in realignment surgeries. So I don't have any financial disclosures. So the effectiveness of toric IOL will depend on correct intraoperative alignment and postoperative rotational stability. So any toric IOL misalignment will lead to loss of astigmatic power. Like 1 degree of misalignment will lead to a loss of 3% of astigmatic power. And when a toric IOL is misaligned of around 30 degrees, it won't have any astigmatic correction. When the toric IOL rotates more than 30 degrees, then it induces new astigmatism. So patients with gross misalignment and suboptimal visual recovery post toric IOL implantation will require realignment surgeries. So some of the methods to evaluate the position of toric IOL in the postoperative period include the common method, which is the slit lamp method. Then we have retroillumination photographs, which are superimposed on axis markings. Then we have the corneal analyzer system. We have some software-based analysis in which the photographs are uploaded to a software and then they tell you the position of toric IOL. Then anterior segment OCT can be used to assess the position, and ray tracing aberrometer. So the advantage of ray tracing aberrometer is it can even assess the position of toric IOL in undilated pupils. So we devised a study to compare the effectiveness of two methods. One is an subjective method, which is an slit lamp method, and an objective method, which is wavefront aberrometer method, to assess the position of toric IOL in the postoperative period. And we also try to document the outcomes of toric IOL realignment surgeries. So it's a retrospective study. All patients who were implanted with toric IOL were assessed on postoperative day 1 and 14. Every patient was subjected to subjective refraction, detailed anterior and posterior segment evaluation. All patients, the toric IOL were evaluated using the slit lamp method and the wavefront aberrometer method. To minimize observer bias, so the slit lamp method was always done first. So slit lamp method, the patient was asked to look at a distance and ensuring that there is no face turn, head tilt. Then a thin slit beam was rotated until it aligned with the toric marks. Then the axis was noted from the slit lamp. So we used the iTrace wavefront aberrometer. So it had an toric check display, which is an inbuilt software. So it will provide data regarding the axis of placement, the objective refraction, and what is the clockwise rotation that is required to correct the misaligned toric IOL. So this is the screenshot of the wavefront aberrometer's interface using the toric check display. So the parameters are given the left bottom. So we'll just magnify it. So it gives what is the corneal astigmatism, then what is the implanted toric IOL's power at the corneal plane and the position of toric IOL, and then the current astigmatism of the eye, and then it predicts an estimated residual astigmatism post realignment of the misaligned toric IOL. So it provides an objective refraction, which in this case is around minus 3.5 diopters at 43 degrees. Then it suggests a rotation of 78 degrees and predicts a change in around 3.42 diopters in the eye. And post rotation, it estimates a residual astigmatism of around 0.07 diopters. So this is how it gives the values. So we included patients who either have more than 10 degrees of misalignment or patients with uncorrected visual acuity of 612 or less, and then they accept cylindrical correction in subjective refraction, and then we predict at least 2 lines of improvement in Selen sort of uncorrected visual acuity. So all realignment surgeries were done within 2 to 3 weeks of primary surgery. So we align the zero axis of the Mendes gauge with the position of the toric IOL, and then the corresponding values which were given by the wavefront aberrometer were marked with the dye on the cornea. Then 2 paracentesis were made, and using bimanual irrigation aspiration cannula. So with in irrigation mode, the aspiration cannula was used to dial the toric coil and align it with the marks on the cornea. So this is an example where post realignment surgery we taken the wavefront aberrometer data. So same data, it shows what is the corneal astigmatism, the IOL power, the astigmatism correction of the IOL at what axis it is. Shows the IOL is at 140 degree now. So when you see the data over here, it suggests only 1 degree rotation, which means almost the toric IOL is aligned to its perfect axis. So we evaluated around 4,721 toric IOL implantations during the 3-year study period, of which 63 eyes met the inclusion criteria for toric IOL surgery, of which toric IOL surgery or realignment surgeries were done in 55 eyes. We included 52 eyes in the data because 3 patients had incomplete data. In 8 patients, the realignment surgery was deferred, like they were either not willing to undergo other surgery or they were happy with their post-operative vision. So the mean age of the study participants were 60.3 years, and the realignment surgeries were done at an average of around 2 weeks from the primary surgery. So misalignment was calculated as the difference between the planned IOL axis and the current axis at the post-operative period. So we found that wavefront aberrometer had a mean misalignment value of 47.1 degrees, whereas using the slit lamp method, it was found that the mean misalignment was around 44.9 degrees. So there was no statistically significant difference. Similarly, post-operative period also, there was not any difference between the degrees of misalignment calculated either through the wavefront method or through the slit lamp method. So we plotted the values in a bland Alpine plot, and it also showed that there is agreement between the 2 methods. So similarly, intraclass correlation also showed almost perfect agreement, and we could see that improvement in cylinder, which reduced from minus 1.5 diopter to 0 diopter in the post realignment period, with a corresponding improvement in visual acuity from uncut at 618 to 6.6. So toric IOLs are effective means to correct astigmatism, provided they are in the correct axis. We found that realignment surgery significantly improves uncut visual acuity, and it reduces the subjective cylindrical correction refraction. And we found that the slit lamp method is as good as wavefront method for evaluating toric IOL surgery. Yeah. So other studies also found that other methods were compared with slit lamp method. So conclusion, toric IOL realignment surgeries are safe, improves visual acuity, and reduces the refractive cylinder. Slit lamp method can be used in resource constrained settings to evaluate the position of toric IOL as good as other methods. Thank you.
So you are a non-ratified member.
Okay.
So marks will not be given.
Okay.
Right?
Next speaker available.
Thank you, doctor.
Thank you.
I request the audiovisual people to please show the timing marker here as well. Okay, it's not being projected here in this. Here.
It's down.
It was not showing.
Okay.
It was not showing. It's 0.06 only since beginning.
Now I invite Dr. Navina Rajendran, paper FP 1100 for her presentation.
Good morning everyone. I am going to present the visual outcomes in a case series of primary piggyback IOL in non-ophthalmic cataractous eyes. Non-ophthalmos is a condition with a short anterior and posterior segment and increased lens to eye volume ratio. Cataract surgery in non-ophthalmic eyes poses problems in terms of IOL power, non-availability of a single high power IOL which is out of range or near the upper limit of power inventories to achieve emetropia. To overcome this problem, the concept of piggyback IOL, that is implanting 2 IOLs back to back, was first described by Gayton in 1993. Our study included 7 eyes of 6 patients with non-ophthalmos whose mean axial length was 16.12 mm and the required mean IOL power was plus 56.5 diopter. Preoperative workup included detailed anterior and posterior segment evaluation with an emphasis on IOP, anterior chamber depth, and endothelial cell count. One patient had advanced glaucoma at the time of presentation and another patient had undergone vortex vein decompression for uveal effusion prior to surgery. Optical biometry with IOL Master 700 was done and the axial length was cross-verified using B-scan, and Hoffer-Q formula was used for IOL power calculation. Coming to the surgical procedure, a prophylactic YAG PI was done for all patients. Intravenous mannitol 100 ml was given half an hour prior to surgery. Subtenance with facial block was given to avoid positive pressure due to lid squeezing during surgery. A standard phacoemulsification procedure with implantation of a foldable hydrophobic single-piece IOL in the bag, followed by implantation of a foldable hydrophobic 3-piece acrylic IOL in the sulcus was done for all patients. There were no intraoperative or perioperative complications like uveal effusion, suprachoroidal hemorrhage, or aqueous misdirection syndrome. 2 patients developed significant anterior chamber reaction with fibrin membrane on postoperative day 1, which was treated conservatively with topical steroids and intramuscular injection dexamethasone. The spherical equivalent reduced from a mean plus 9.75 diopter preoperatively to plus 0.75 diopter postoperatively. Mild interlenticular opacification was noted in 2 eyes. 1 patient had widespread pigment deposits over IOL with optic capture and tilt of the sulcus placed IOL. No major postoperative complications like significant interlenticular opacification, PCO, or secondary pigmentary glaucoma occurred during the mean follow-up period of 2 years. This is a table showing the preoperative and postoperative data. You can see that the minimum IOL power we placed was 47 diopter and the maximum IOL power placed was 63.5 diopter. We did not reduce the power for sulcus implantation as we aimed to leave the patient slightly myopic after surgery. Even then, in the postoperative refractive correction, you can see that we landed up in a mild hyperopic spherical equivalent after surgery in 3 patients. Visual acuity improved in 5 eyes, remained unchanged in 2 eyes, and the visual acuity was poor in 1 eye, which was 5/60 because of glaucomatous optic nerve damage. Ultrasound biomicroscopy was done for all patients, which showed well-centered piggyback IOL with 1 in the capsular bag and 1 in the ciliary sulcus in 6 eyes, except in 1 eye, which is shown in figure E, which had an optic capture and tilt of the sulcus placed IOL. Mild interlenticular opacification in the form of Elshing pearls nasally was noted in 1 eye in figure B. Figure D showed a mild thin thread-like nasal ILO. In figure B, C, and E, you can see precipitate-like deposits, discrete clumps close to each other, occupying a small area in the central interface, similar to those described by Eleftherides et al. All these ILOs did not cause any visual disturbance. Discussion. Another option in anophthalmic patients is to place a customized high-power IOL. An IOL with a power of greater than plus 40 diopter would have very steep radii and would behave more like a sphere, inducing increased spherical aberration, reduced modulation transfer, and compromised resolution. Piggyback optical systems induce less spherical aberration and provide superior image quality when the optical centers of the 2 IOLs are aligned than a single high-power IOL of the same power. And eyes with multiple acrylic implants demonstrated a substantially greater depth of field compared with eyes with single acrylic implants. We decided to place a 3-piece IOL in the ciliary sulcus to prevent inflammation and iritis caused by a single-piece IOL in sulcus, and we did not notice significant ILO in any of our patients, probably due to the space created between the 2 IOLs by sulcus implantation. In conclusion, implanting 2 piggyback IOLs, 1 in the capsular bag and 1 in the ciliary sulcus, gave good results in eyes with an extremely short axial length. No significant interlenticular opacification, posterior capsule opacification, or secondary pigmentary glaucoma occurred up to a mean follow-up period of 2 years. However, using IOL Master 700 and Hoffer-Q formula underestimated the required lens power, resulting in a mild hyperopic refractive error after surgery. These are my references, and thank you for the opportunity.
Excellent presentation, but I was wondering, why did you not put a single IOL of the power which was required? Because now the Indian companies are giving the full complete power IOL 55, 60, whatever you want,
Yes, sir.
of a particular size. Like if you have a nano ophthalmic eye, then even the smaller lens and all these things, you can ask them to make accordingly.
Yes, sir.
Of your choice.
When we did a literature search, we found that piggyback optical systems gave a better visual acuity for the patient. That's what I
see. If
included
you
in this
another question is how to calculate a piggyback power of the piggyback IOL.
Yes,
because if there is a residual power of 5 to 6 diopters, the piggyback IOL required is of plus 10 diopters.
Yes.
It's a much higher than what you actually calculate on refraction or whatever. So you are putting overall thickness of the two lenses is much more than the single lens, and also you are putting single lens in the bag compared to one in the bag in the sulcus. So I feel that with the current scenario where your IOL power and the size can be met with by the customized lenses, customized IOLs which are available, that's a better option, I believe.
Okay, sir.
Anyway,
Thank you.
nice presentation, but keep this in mind next time.
Yes, sir. Thank you. That's it, sir.
Thank you, Doctor. Since you are a non-ratified member, you will not be marked for that. Thank you.
Well, may I invite the next speaker, Dr. Jayantan, to tell us more about the visual and optical performances after unilateral implantation of toric multifocal intraocular lenses.
Thank you, sir. My presentation will be on the visual and optical performance after an unilateral implantation of the toric multifocal intraocular lens. I have no financial interest in this. So the purpose of the study is to evaluate the visual outcome and the patient satisfaction after an unilateral toric multifocal intraocular lens implantation in patients with cataract and corneal astigmatism who are unhappy due to the refractive surprise in the other eye which is already operated. So this is a prospective case series where 21 patients with cataract and corneal astigmatism and a motivation for spectacle independence were enrolled for the study after informed consent during the period of January 2021 to August and had a cataract surgery with implantation of toric diffractive multifocal IOL. Postoperatively at 1 week, 1 month, 3 months, the binocular and uniocular uncorrected distance, near and intermediate visual acuities, residual refractive astigmatism, contrast sensitivity, subjective patient satisfaction were evaluated using the questionnaires. A significant cataract and corneal astigmatism warring toric IOL, a patient who had IOL surgery earlier and had a residual refractive error in the other eye, and who had a motivation for glass independence, who are self-motivated, realistic expectation patient were included in the study, and who had unrealistic expectations, who had significant corneal or macular pathology or previous other ocular procedures were excluded. The IOL power was calculated based on each patient's corneal curvature, axial length using a lens or optical biometer, and the SRKT and Barrett formula were used. The pentacam analysis was done to confirm the corneal symmetry, K values, and the axis. Toric calculation was performed using the company's own calculator. The surgery was done by a single surgeon under topical anesthesia with the manual slit lamp marking done. There was no intraoperative complication and no sutures were placed at the end of the procedure. Postoperatively, all the postoperative examination, including the visual acuity at near and far distance, contrast sensitivity, IOL axis, completion of the questionnaire were carried out at 1 week, 1 month, and 3 months postoperatively. The corrected distant visual acuity was done at 6 meters using a Chelensat. Intermediate was done at 66 centimeters, and near visual acuity was captured at 33 centimeters. The mean visual acuity was expressed as log-mark scale. The statistical analysis was performed on the SPSS version 20 for Windows. The continuous variables were presented as mean plus or minus standard deviation. The Saphiro-Wilk test tested the normality of the data. Quantitative variables between the study eye, the contralateral eye, binocular, uniocular eye vision were compared using the Wilkinson sign rank test. The two-tail p-value less than 0.05 were considered to denote statistically significant differences. Subjective assessment, the patient were asked 6 questions about their satisfaction at the 1 week, 1 month, 3 month postoperative period, including question about their need for glasses, discomfort from glare under the mesopic and photopic condition, and they were graded under a 3-level scale. The study included 21 patients, of which 4 were male and 17 were female. The mean age was 61. Out of the 21, 12 had their right eye operated and 9 had their left eye operated. The mean IOL power was 21. Mean axial length was 22. The mean preoperative astigmatism 1.96 plus or minus 0.5. This is the demography of the other eye, which was already operated. So the IOL positioning postoperatively was maintained throughout the postoperative. There was no significant rotation. It was all on axis. Coming to the postoperative visual acuity, comparing the study eye logmark visual outcome with the mean standard deviation of 0.06 plus or minus 0.09 and the contralateral eye logmark visual outcome with mean and standard deviation of 0.3, the mean difference is 0.24. This shows the significance value is 0.001, which is lesser than the 0.05 value. So the level of significance shows that there is a highly significant difference between the study eye and the contralateral eye. At 3 months, the patient had a binocular visual acuity of 20/20 or better, and it was noteworthy that the binocular results were better than each monocular result at all distances during every postoperative visit due to the binocular summation. The mean binocular uncorrected near visual acuity was 0.01 logmark unit. The refractive stability was maintained throughout the postoperative period till 3 months. A total of 90% of the patient responded that they initially only experienced a minimal halo and a glare at 1 week postoperatively, and this increased to 95% at 1 month. Finally, by 3 months postoperatively, only one patient responded that they experienced a moderate halo and glare. And none of these patients required glasses for any of their activity for the far, intermediate, and the near visions. So only a few studies has reported outcome, and of course there was no study which has been performed about the toric multifocal IOL implantation in patient who has already undergone a unsatisfactory cataract surgery with IOL time ago. At 3 months in our study, all the patient had a binocular cumulative visual acuity of 20/20 and better. The postoperative spherical equivalent refractive accuracy was within 0.5 in all these eyes. Refractive cylinder accuracy within 0.25 in all these eyes. The mean binocular near visual acuity was 0.01 logmark. The reading speed at 40 and 60 centimeters shows consistent improvement over time. Not only the objective but also the subjective satisfaction was important for cataract surgery. We also used a questionnaire, so it shows that the less than 10% of the patient were uncomfortable with halo and glare throughout the postoperative period. At 3 months post-op, no patient had complaints of severe dysphotopsia, and none of the patient required glasses for any of their activity. So to conclude, toric multifocal IOL provided a complete visual restoration with a good visual outcome. Even when implanted unilaterally, the incidence of dysphotopsia was low, spectral independence was high, resulting in a good patient satisfaction. Thank you.
Thank you so much. How much you rely on the machine for calculation of the IOL part on the machine?
Sir, usually we do both optical and immersions. Whenever the agreement between both the results are there, we directly go with it, sir.
Do you go for any record of the old refraction of the patient, because the expectations are very high?
Exactly, sir.
So actually I want to share with the audience. We got LensStar 900 and the case was mature cataract, and our center is a very high volume center. So I'm doing surgery for last 40 years, IOL. And the LensStar was giving the power 14 diopter pre-operative. And otherwise I was already operated somewhere else, 6/6. So we believed the LensStar. It was a mature cataract. And the operator who calculates the lens power has got the experience of 30 years, but he believed on the machine. So we convinced the patient that she has got unilateral problem probably, and we missed the conventional method of calculating. We were so excited to have the machine, and the post-operative, the error was +4. The machine was wrong. So this happened last week only. So we changed the lens. So my suggestion is, after doing 1 lakh IOL surgeries, don't purely rely on machine. Go for your sixth nerve sense and try to check with the refractive errors if the patient is having, because expectations are very high for multifocal. The patient is spending money, so you must be doubly sure. Don't rely on the machine only. So Dr. Bharti, what do you say? We should go blindly for the machine. We should rely, or
I feel that the optical biometer is not going to work very well
in the mature
cataract.
Yeah, I agree.
So I think the
So what should you do for the mature cataract then?
Sir,
go back to conventional system.
Sir, I was actually lucky enough because my father is an ophthalmologist and he does a immersion for the last 40 years. So I rely on LensStar. My father does it on immersion. We compare it, sir. So all these patients had a comparative IOL power. That's when we implanted it.
That's my message is, if you invest 50-60 lakhs, still you should believe yourself. Go for old refractive error the patient is carrying, because mostly they are educated patients and they are carrying old refractions. So you must counter check.
Yes.
That is my point.
Thank you, sir. Thank you.
Thanks so much.
Thank you, sir. Thank you, sir.
Hello. Yeah. May I invite the next speaker, Dr. Anuj Satija? He'll be speaking on retrospective assessment of accuracy of 9 intraocular lens power calculation formula in myopic eyes.
Okay. Good morning, everybody. Good morning, respected judges. I'll be talking on the accuracy of 9 IOL power calculation formulas in cases of axial myopia. I have no financial interests. The problem statement comes that in high myopia, there are multiple pitfalls in IOL power calculations because of the inaccuracy in axial length measurements, which ends up leading to effective lens position prediction errors and ends up with hyperopic surprises. And this is proven that the challenges of high myopic cataract surgery are higher. So along the entire literature, multiple comparisons have been done for all the IOL power calculation formulas that have been used, and it's been found recently that the AI-based formulas, the newer generation formulas, end up performing better. So the aim of our study was to compare all the newer generation formulas with the older generation formulas, along with the use of Bangkok adjustment for the older generation formulas, which improves the accuracy in myopic cases. So our setting was a tertiary care center in Bangalore. Recruitment criteria it was a retrospective comparative study, and we used data from patients who underwent uncomplicated phacoemulsification. Their axial length was greater than 26 millimeters, and they did not have the exclusion criteria included no other ocular pathology and lower than 26 mm of axial length. Biometry was done using LensStar because that is something we'd been using all along. And the IOL power calculation formulas used were Kane, Barrett Universal 2, EVO 2.0, Hill RBF 3.0, Olsen formula, along with Bangkok adjustment for SRKT, Holiday 1, Haggis, and Hoffer Q. So our the mean age of our patient demographic was 53 years. And there were 165 patients that we were able to recruit in our study. Our results showed that the outcome was decided based on absolute prediction error, the median absolute prediction errors based on all the formulas. So the lowest absolute prediction error was with the Hill RBF 3.0 along with the Kane and the EVO 2.0. This is the table for the prediction errors that ended up coming, and as based on the study by Holiday et al., it says that since the normality was it was not normally distributed, the median absolute prediction error is what should be used. So we compared it on the basis of median absolute prediction errors. The Hill RBF ended up having the highest percentage of eyes with outcomes within 0.25 diopter sphere, along with the Kane and the EVO as well. In all of them, the distribution of the population with the lowest prediction was with Hill RBF 3.0. So coming to the discussion, with IOL power calculation formulas having had evolved over the generation, depending upon the number of variables used, the newer generation formulas use more number of variables and they also use artificial intelligence, which leads to better prediction capacity of the newer generation formulas. The theoretical formulas, they rely simply on mathematical principles, and the regression formulas work backwards based on the outcomes that have come. And the third and the fourth generation formula use both, and the artificial intelligence based formulas use higher mathematics and complex equations to figure out better prediction accuracy. So what makes the newer generation formulas better is that they use the original theoretical model with regression and combine it with artificial intelligence. They end up using multiple variables, more number of variables for prediction of ELP and therefore prediction of the eventual IOL power. So in our cohort, Hill RBF 3.2 performed the best amongst all the lenses. It had the lowest mean and median absolute prediction error along with the lowest standard deviation. Also, it had the highest percentage of eyes across the outcome dioptric range. Kane and EVO 2.0 were not significantly worse. And since these formulas are artificial intelligence based, with the increasing data set, these formulas keep getting better. So the performance of these formulas are expected to keep improving. So the conclusion is that the newer AI-based formulas demonstrate a significant improvement over the older generation formulas across all axial lengths. But this prediction error of the older generation formulas, also with the Bangkok adjustment, was in the range of say 0.35 or 0.37 as the prediction error, versus of the AI-based formulas coming to 0.27. So even though this is it was statistically significant, it may or may not be clinically significant. So what the study adds is that the accuracy of the formula of the newer generation is significantly better, especially in extreme myopic eyes. We ended up dividing the population into 26 to 28, 28 to 30 mm for axial length, and more than 30. The prediction was better and significantly better in the higher axial lengths. The higher the axial length, the better it is if you use an AI-based formula. The limitations of the study was that we checked this at 3 months post-operatively. The refraction was at 3 months post-operative, and a single IOL was used with multiple surgeons. Thank you.
Nice presentation.
Thank you, sir.
But I don't like your statement. Kane is not significantly worse than Hill RBF.
It was.
Personally, I feel Kane is the formula for small eyes, large eyes, normal eyes, whatever. That is the best formula which gives you the accurate IOL power prediction. Compared to Hill RBF, which has got its own limitation for smaller eyes. So none of the formula works well for a range of eye sizes. So this is where I think that you have tried to put Kane as a okay, this also is there.
Right.
I think Kane is superior.
So
that's what my feeling is. And I use Kane for yes, go ahead.
We initially began the study with just 3 formulas that we used: SRKT, Barrett, and Kane. And Hill RBF 2.0 was originally used. In that, Kane and Hill RBF was found exactly the same. Later, we ended up, when we sent the paper, it was asked for other formulas to be used as well. And when we recalculated everything, and then we recalculated with Hill RBF 3.0, we found the median absolute prediction error to be lowest amongst Hill RBF 3.0. No financial interests or anything. And it was not significantly worse. So Hill RBF, EVO, Kane, all of them work very well. It didn't say that Hill RBF performed, the statistical significance was not better.
So the message should be that all the three
AI-based formulas
are equally good for myopic eyes. But if you go ahead and do a study with a smaller eyes and a spectrum of all the axial lengths, then probably Kane will become slightly superior to all others.
Okay.
Wonderful presentation.
Thank you.
What is the target refraction case of myopia you want to keep?
So now we keep target refraction as 0 only, sir.
We plan
emetropia. We plan for emetropia. Yes, sir.
Patients are happy?
Patients are happy, sir.
0. Okay. I just keep minus 0.75 because whole life the patient has used glasses, and sometimes even my mother, she achieved 0, but she was still using glasses because the glasses was the part of her face. So I mean, this is my experience. For myopic, if you keep -1, so near vision also is a profitable option. So that is my take on that.
We end up discussing it with the patients, sir, usually. If the patients are informed about both, and if the patient is willing to have a little bit of monovision or a micro monovision, we plan according to what the patient requires, sir.
Okay. Thank you. Thank you.
Thank you, sir.
Yeah. Now I call upon Dr. Shivkumar Chandrasekhar for his paper 1419. Last.
Respected chairpersons and delegates, I'm grateful for this opportunity to present the paper, Refractive Change over 5 years after cataract surgery with capsulorhexis overlap versus no overlap. As we all know, cataract surgery has evolved into a refractive surgery, and the recent advances have ensured achievement of emmetropia or a refraction target. One intraoperative factor having a great bearing on the refractive outcome is the capsulorhexis, which should be well centered and well sized. But the most important aspect of that is a 360-degree overlap over the optic of the IOL. The studies have shown the importance of this and also have demonstrated with imaging an IOL shift, decentration, and tilt, which happens because of lateral capsular back contraction. And with a partial or a lack of overlap, this can increase the effect. So the aim of the study was to compare the change in refraction over 5 years from that of the first month in patients with a 360-degree overlap and those without a 360-degree overlap. The patients were from the control group of a larger study, a 10-year-old study on pseudoexfoliation called the Aravind pseudoexfoliation study. And these patients underwent phacoemulsification with a foldable hydrophobic acrylic IOL in the bag implantation. These patients with senile cataract had no pseudoexfoliation, a pupil dilating more than 5 mm, no comorbidity, and a corneal astigmatism of less than 1 diopter. And in this study, there were 2 groups, those with 360-degree overlap seen post-operatively and where the IOL had not covered by more than 1 clock hour with a partial overlap were in group 2. Only the patients who had attended all the follow-up visits of the original study were considered in the study, and complete refraction data had to be available for the first and third months, and first, third, and fifth years were taken for analysis. The following patients' data were excluded: those with intraoperative PCR, those with PCO, and those who had undergone YAG capsulotomy following PCO. So in the first group with the total overlap, we had 240 patients, and in group 2, we had 75 patients. The spherical equivalent of the refractive correction at 1 and 3rd months and the first, 3rd, and 5th years were taken, and the change in the spherical equivalent at each of these intervals from the first month was noted, and the percentage of patients with a hyperopic myopic shift or no shift was taken. When we looked at the average spherical equivalent at each visit, we found that with the overlap, the mean was 0.01 at the first month. There was a hyperopic shift of the mean to 0.18 at 1 year, and which gradually increased to 0.25 at the 5th year. Whereas in the other group, there was a wider variation, a variable refraction with 0.04, a myopic shift in the 3rd month, gradually becoming hyperopic, and finally ending at 0.13. And the change in the first year in the first group was significant. When we looked at the median also, both the medians in both the groups were 0, but the interquartile range was a little higher in the second group, suggesting a wider range of refraction. And there was a hyperopic shift which was to be noted from the first year onwards in the median in the first group. Looking at the amount of change also reflected the same thing. The change was usually the hypermetropic side in the first group, while it was myopic in the initial stages and hypermetropic later. When we looked at the shift of refraction from the 3rd month, at the 3rd and 5th year, we saw that there was a hyperopic shift as a majority, but it was more in the second group. And 1/3 of the patients, or those with overlap, did not have any change in refraction. When we looked at the percentage of patients with a spherical equivalent within 0.5, plus or minus 0.5 at 1 month and 5 years, we saw that it had dropped from 80% to 70 to 73% in both the groups, and they were comparable. And clinically, this would translate into the patients, 70% of the patients preserving their uncorrected visual acuity at 6/12 or better. Shift in IOL, decentration, and tilt can cause compromised vision, periodic changes in refraction and glasses, and therefore a dissatisfied patient. Decentration beyond 0.4 mm, a tilt beyond 5 degrees is found to be critical. In our study with the rhexis overlap, we found a hyperopic shift in the mean more within the first year from 0.01 to 0.8, but this hyperopic shift continued very gradually for the next few years. At the 5th year, it was 0.25, and the median also shows a hyperopic shift from 0 to 0.25. But in group 2, with a partial overlap, there was a myopic shift to start with, and thereafter a hyperopic shift. And the larger interquartile range of 1 diopter in group 2 also suggests that there was a wider range of refraction. Comparing the direction of the shift, we saw that 1/3 of the patients with overlap had no change. With partial, 20% had no change, and both groups had a hyperopic shift, but it was more so in group 2. The studies have shown a significant shift of optic in cases without an overlap, but there are no significant changes between a complete and a partial overlap. And that is because the study says that an area of cover is more important rather than the degree of cover. And so this explains the equivocal results of our study, as all patients are at least a partial overlap. To conclude, a 360-degree overlap of the CCC gives a better stability of refraction. There's a wider variation in refraction over time in group 2, but this is not significant. And the majority of the patients of both groups may not have a noticeable change in refractive error and visual acuity over a period of time. But having said this, further studies are needed to study the changes in higher order aberration and the quality of vision between both groups, as this may be what determines patient satisfaction. Thank you. Thank you, sir.
One more. Thank you very much. Now we call upon the last speaker, Dr. Sangeet Bhatnagar, for his presentation.
Good morning, everyone. I am Dr. Sanket, and I'll be presenting my study on comparing accuracy of toric power calculations with an anterior segment swept-sort OCT with standard devices. I have no financial disclosures. So, with increase in incidence in astigmatism and demand for better, more accurate post-operative results, conundrum of solving astigmatism power in phacosurgery has been there for phacosurgeons for quite some time now. So whenever we want a precise or accurate biometry, we need good topography, good axial length measurement, pachymetry to come to a conclusion that, okay, we can give a reduced SIA post-operatively. So there are a number of machines at our disposal, most of them biometers, topography, abrometry, but most important or most pivotal is topography and biometry for toric calculations. But whenever we send our patients, most of our patients are in senile age group through these battery of tests or scans, what we see it's very cumbersome, very time consuming, and also it puts a financial strain on the practitioner as well. Thus, COVID also has shown that we should shift our protocols. We have to shift to lesser contact points and shorter imaging protocols now. So this begs us to ask that is there a single imaging platform which is reliable or which can give us comparable, if not more precise biometry or keratometry for toric calculation compared to standard devices that we have already. This brings in the Heidelberg Anterior ASOCT into picture, which is a multimodal imaging platform which is optimized for anterior segment imaging. It utilizes high resolution sepsis OCT with 1300 nanometer wavelength, which gives us larger scanning depth of around 31 millimeter, and has low scatter. It also combines topography and tomography with biometry measurements, has eye tracking technology for faster acquisition time, and Oculix, which is a ray tracing software which you can incorporate into the machine itself. So a single imaging platform can give you biometry, topography, anterior segment imaging, and it has an inbuilt toric planner. But can it replace our standard topography and biometry devices? So that's where we conducted the study, with the purpose being to compare the reliability and agreement of parameters which were measured between Heidelberg, Anterior, Carl Zeiss, IOLMaster 700, and Oculizer. We also studied the residual corneal astigmatism post-operatively, which was achieved by Anterior and with conventional devices, and we assessed the mean prediction error as a gauge of accuracy. So it was a prospective interventional study of 42 eyes of 32 patients who between 50 to 75 years of age had acquired senile cataract with an astigmatism of more than -1 diopter with normal corneas, no other ocular pathology, and no previous ocular history. All these subjects underwent clear corneal phacoemulsification by a single surgeon, where a temporal 2.2 millimeter incision and a toric monofocal aspheric IOL implanted. So pre and post-operatively, the patients underwent visual acuity, refraction, and detailed slit lamp examination. Mean keratometry, astigmatism, pachymetry, axial length, and IOL biometry was measured from both IOLMaster and Anterior. And from Oculizer, mean keratometry, astigmatism, and pachymetry were measured. So coming to the toric planning, we compared the biometry and topography from IOLMaster and Oculizer, and we used the Alcon IQ toric calculator. Parallelly, in anterior, the biometry and topography gave us the measurements with the same formula, which was SRKT and A constant, and whatever we got from the Oculizer and IOLMaster, we incorporated into the Alcon calculator, and Alcon AccuSoft IQ toric monofocal lens was implanted. Coming to the results, in a sample size of 42 eyes of 32 patients, the mean IOL power implanted was plus 23.25 diopters, and there was a statistically significant change in visual acuity, change in corneal astigmatism, and mean spherical equivalent. Now, to survey the repeatability of the parameters they were measured, intra-class coefficient was evaluated, and Antirian showed moderate to good repeatability with excellent repeatability for axial length. Now, comparative analysis of all the parameters that were measured, which were mean preoperative astigmatic power, keratometry values, axial length, and pachymetry, though there was no statistically significant difference, but there was no variability also between the devices. Coming to the Bland-Dolman plots for agreement, both Antirian and IOLMaster showed favorable agreement with excellent agreement shown for axial length. And axial length was so much agreeable that we saw that it can be interchangeably used also. Now, coming to the mean prediction error, our accuracy was gauged by the mean prediction error, which was calculated as a difference between the target or the predicted actual residual astigmatism and the actual that we achieved. Though it was not statistically significant, but Antirian calculator gave us a lower predictive error compared to the online calculator. Also, the keratometric error the range was lesser in Antirian. So what we already know is that predictive accuracy of toric IOL power calculations depends on both precise biometry and keratometry, and multiple biometers and keratometers are available, and a composite workup on all these is required to do a toric IOL power calculation. But what this study adds is Antirian shows good to moderate to good repeatability, and good agreement between Antirian and IOLMaster is still present, and it has a lower prediction error in toric calculation compared to toric calculation which was done by conventional devices. Just to conclude from this study, Heidelberg Antirian with its longer wavelength and larger penetration depth can be used as a single platform biometer and keratometer for toric IOL power calculations, but this study was not without its limitation. We had a smaller sample size, and the follow-up period was only 1 month post-operative period. Also, the toricity of the IOL implanted was not taken into factor, which can be a confounding factors also. Also, vector analysis is still to be done because the sample size is a little low. So that's for the future direction. Thank you.
Thank you, Doctor. That was a good presentation.
So, just for the sake of knowledge,
yes,
Antirion also gives you a posterior float.
Sir, it gives us a posterior float. It gives us a total
as good as the Pentacam.
Sample size is less, but reliability is good, sir.
Okay.
Plus, it can give us a epithelial thickness map also, sir. So on anterior
so that is not for cataract surgery. Epithelial thickness.
Posterior float, it's giving.
Posterior float is more important when you're talking about toric IOL.
Yes, sir. So it uses that as a parameter for toric planner, which is incorporated into that, sir.
Okay.
Yes, sir. It gives.
Okay. Thank you.
Thank you, sir.
Yeah, that brings us to the end of the session. Thanks to Dr. Partha and the scientific committee for giving us this opportunity. We'll have a photo session with the. We will finish the marks. Yeah, the speakers kindly wait. We'll have a photo session with all the.